Are we live now, Surya?
Yes, sir.
Okay, thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Dear colleagues and friends, welcome to Myom Academy and to episode 3 of Macular Surgery module. And today we are going to have an episode about vitreomacular traction, VMT. And also, as usual, from the first episode until now, we are having a very eminent speakers from different parts of the world that they are going to share with us their experience, and we'll get a lot of information. The co-moderator for this session and the one who makes this module actually, Dr. Muhammad Awadallah, my dearest friend, Professor of Ophthalmology, Cairo University, Egypt, Consultant Ophthalmologist and Vitreoretinal Surgeon. Our speaker, Dr. Ayman Midanat, he apologizes. He has some issues that he cannot join us, unfortunately. So we'd like to welcome my dearest friend, also Dr. Hussein Khakan. He's a professor of ophthalmology, Department of Ophthalmology, Lahore General Hospital, Amiruddin Medical College, Postgraduate Medical Institute, Lahore, Pakistan, Vitreoretinal Surgeon, President of Pakistan Vitreoretinal Society. Welcome, Dr. Hussein, and thank you for giving us a chance to meet you and learn from your vast majority of experience. Also, today I have an honor and pleasure to have with us Dr. Maria. She is a CEO, Doctors Vera Cole and Associate, MD Ophthalmology Specialist in San John, Puerto Rico. She's a vitreoretinal surgeon, and thank you for giving a chance also and to be with us. And she is just joining us, and after she just landing, I think, from coming to San Francisco, I think that's what I do remember. Thank you, Dr. Maria.
It's an honor to be here. Thank you.
Thank you. Finally, and the last and not the least, my dearest friend, Dr. Prasan Rao, is a specialist ophthalmologist, vitreoretinal surgeon, medical director, Medcare Eye Center, Dubai, UAE. Dr. Prasan, one of the pioneer vitreoretinal surgeon in UAE. Agenda for today. So today it's going to be one part, and it will be a vitreomacular extractions. We will have a voting system first. Every time one question, then we will have a comment, and then their colleagues, they will show their experience in different videos. And now I shift the mic to my dear friend, Dr. Awadallah, please.
Thank you, Dr. Muhammad, for this opportunity. And this is the third episode, as you mentioned, about vitreomacular traction syndrome. We first, as usual, we post some basic questions for the audience as a kind of self-assessment, and then we'll have the discussion after each with the esteemed panelists. So we can start posting now the first question. Yes.
Okay. Can we read? Okay. Can we read the music? Sorry about that. So vitreomacular attachment, VMT, is associated with all of the following concepts.
So as a start, we need to differentiate between two categories: the vitreomacular attachment and the vitreomacular traction. And the first question was about what is basically what's vitreomacular attachment. So we had here mixed opinions. Maybe the word, except some of the attendees didn't notice that. So would you, Dr. Maria, comment on the difference between both categories, the vitreomacular attachment and traction?
Yes, vitreomacular attachment does not necessarily cause elevation of the retina. You can have attachment without having traction on the retina. So the angle would be, you would have an acute angle if you have traction, but not necessarily with attachment.
Okay, and basically, do you think vitreomacular attachment, just the attachment, can cause symptoms in patients?
Usually not. Usually when you only have an attachment, the patients tend to be asymptomatic.
Okay, great. So basically, as Dr. Maria said, it's all about the structural integrity of the macula. So if it is not affected, we would say it's just adhesion or of the vitreous to the surface or attachment. But traction, basically, there should be some structure integrity affection of the macula. You agree, Prasad?
Yeah, I think when you're looking at differentiating between vitreomacular adhesion and traction, we generally try and look at the contour of the fovea. And we know the contour of the fovea is generally a U-shaped contour. If this contour gets disturbed for any reason with the adhesion, that would contribute to a traction. And this is an anomalous form of PVD. Normally, as you know, the PVD starts in the perifoval area, then it extends to the periphery, and then you have the separation of the from the macula, and then eventually from the disc. However, whenever there's a separation happening in the macular area, if there's traction or the forces of traction are more stronger than the adhesions, then eventually the macula gets lifted, and that's the way we differentiate between adhesion and traction.
Okay, great. Maybe the second question, we can post the second question, which explains more about this. So let's see what's the results of the this. So the question says the vitreomacular traction is characterized by any of the following except. Again, there is a mixed opinion, and 53% of the attendees think that full thickness retinal defect can be considered vitreomacular traction. I mean, it's a full thickness macular hole since it's a full thickness retinal defect. So let's have what's the opinion of Professor Hussein regarding the structural affection of the macula in traction. Dr. Hussein.
Yeah, you are mute before. Okay, please. Yeah.
So vitreomacular traction is characterized by any of the following except single curve. So what's the question? Can you repeat the question, please?
Basically, some of the attendees voted for full thickness macular hole as a part of the traction. Do you consider the vitreomacular traction when there is some integrity affection of the macula, not including the macular hole, right? So this is about the question. So if you have a full thickness defect, this will be another category, which is the macular hole, not the VMT.
Yes, sure. The VMT only we describe it when it is have attached part over the foveal and parafoveal area. When it's not attached there and it has created full thickness macular hole, then it should have been separated from the lip. It may be attached on the other lip of macular hole, but even if it is attached on the other lip of the macular hole, either temporal or nasal or superior inferior, then it has nothing to do with the VMT. It's no more a VMT. It's a straightforward a macular hole of stage 2 or stage 3, whatever you get at that time. I think so.
So, Dr. Maria, full thickness macular hole could be the result, the end result of the VMT, right?
Exactly. With a VMT, two things can happen. Either it detaches completely with resolution of the traction by itself, or it progresses to a full thickness macular hole.
Okay, great. So now,
Dr. Abdullah, if you allow me, can we go to the, to the question and, comment about each one, so that will enrich about the.
With vitreomacular traction, you can have a foveal detachment from the retinal pigment epithelium. You can have a formation of some intraretinal cysts and cavities. You may have some subretinal fluid, but if you have a full thickness retinal defect, that would be another category, which is the macular hole, which could be the result of vitreomacular traction. So this is
the correct answer. It should be the C.
C, except, okay.
So I need.
Of course, you can have both together. I mean, the VMT, as Dr. Maria said, you can have attached vitreomacular attachment to the operculum or flap of the retina in the formation or not.
Can I
ask?
Sure, Raf.
It's a very good point that you have a full thickness macular hole. So the tip here or the pearl here is when you're looking at the OCTs, you should ideally look at all the raster scans, and preferably if you have radial scans as well. But sometimes if you have an eccentric scan, you might feel that the patient has actually a vitreomacular traction. But if you look at subsequent scan, there might be a small hole somewhere. So it's very important not to comment just by looking at one scan whether the patient has traction, only vitreomacular traction or no. So it's important to look at all the scans.
Yes, excellent. So you have to look.
I have a suggestion, Dr. Abdullah. If we can read the question very easily, slowly for the attendees, because I think it will be difficult for them to read and to choose. So we can take a little bit more of time. And if there is anyone of the colleagues, if you don't mind, he can show any video to show this idea that if there is someone
yes, as we go, I think Dr. Rao has
if you have anything in questions that can follow any question and you want to show Prasan, you can go ahead if you want, or Dr. Maria or Dr. Hussein, any one of you.
Oh,
sure.
Can I share my screen? I'll just show a few slides before we proceed quickly.
Sure.
Yeah. So my slides are seen?
Yeah, sure.
Yeah. Sorry about that. 1 second. Okay. So we actually rely upon this. This is a very important landmark paper, the International Classification of Vitreomacular Traction Study, which was published in Ophthalmology. So these are the OCT-based diagnoses. So here you're looking at vitreomacular adhesion and vitreomacular traction. And the OCT-based diagnosis is one important thing which you can rely upon. So this clearly mentions partial vitreous detachment and persistent vitreous attachment to the macula. And as mentioned, you should have an acute angle between the posterior hyaloid and the inner retinal surface. Sorry about that. Okay. And also there's absence of a change in the foveal contour or retinal pathology. So this helps you to differentiate between the presence of traction or no traction. And if you look at the features of vitreomacular traction, they are similar to the ones in adhesion, except for the presence of change in the contour, which is distortion of the surface, intraretinal changes, elevation of the fovea from the RPE, as Dr. Abdullah mentioned in his question, or any combination of this. But most important is absence of full thickness interruption. So the moment you have presence of a full thickness interruption, as mentioned, this is full thickness macular hole. And just one more slide about what is the severity wise. So the OCT-based classification talks about focal and broad. So the important point to remember is it is the size of one disc diameter. So if you have a broad focal attachment which is less than 1500 microns, this is considered as focal. Anything more than 1500 is considered broad. And if you have concurrent disease like comorbidities such as age-related macular degeneration, vein occlusion, diabetes, it's considered as a part of vitreomacular adhesion, or if it's not associated with any condition, it's isolated.
Great. This
So,
is yeah.
So I'm showing you this slide because when I was doing my fellowship, we didn't have the option of using OCT because the OCT came only after the end of my fellowship. So how do we look at patients with vitreomacular traction? And so in those days, we were taught that if you see a patient who's got this fine taut posterior membrane, sometimes with a cystoid change, in the absence of a posterior vitreous detachment, you should think of vitreomacular traction. So I'm talking about days when we didn't have the OCT. And this is how it would look like on a clinical exam. So normally, a lot of doctors would ask me, doctor, okay, when should I suspect vitreomacular traction? So these are the clinical features you want to look at. This fine taut membrane which is sitting on the surface, cystoid changes, and you don't generally see a PVD. And this helps you to differentiate between epiretinal membrane because epiretinal membrane generally will have an associated vitreous detachment. This is on autofluorescence. Sometimes the cysts will actually glow. And this is classically on OCT how you see. And you can also appreciate that there's a small area of subretinal fluid in this patient. Yeah. So I'll stop my sharing.
Thanks for sharing. It's very obvious the vitreomacular traction, and we can see the changes and the cysts in the macula, sometimes with the separation from the RBE. So it's very illustrative. Thank you for sharing, Prasan. Well, let's move forward to further question. So vitreomacular traction is an indication of treatment if, vitreomacular attachment, VMT, is an indication, VMA, it should be VMA, is an indication of treatment if the patient is asymptomatic. So as we can see, 70% of attendees agree that vitreomacular attachment is an indication of treatment, even if the patient is asymptomatic. So we can have Dr. Hussein opinion. Dr. Hussein, if you have a patient with just vitreomacular attachment or even with traction, and the patient is asymptomatic, would you go for treatment? Well, what's your management for this patient?
Okay, so we should consider the two things here. These are very important. Whether we are going to treat an OCT or whether we are going to treat the patient's VN. So if the patient is asymptomatic and there is no visual problem, then why to treat it? Patient wouldn't be thankful to have a good vision, natural vision, and then you give him an artificial vision like after the surgery. So first thing is that we are treating the patient vision. If he doesn't have a symptoms, we are not treating that eye. Second thing is, if the patient having the symptoms due to the VMT, and then it's a disease, and then we will treat it. Without symptoms, I'm not going to treat it unless I'm not seeing the sequelae of VMT that may cause the permanent visual loss or temporary visual loss that may come after the sequelae of VMT. So my preference is treat the symptoms of the patient, not the OCT.
Great. Dr. Maria, do you have a comment on this? You follow the
Yes,
same?
I agree completely. Even if patients are symptomatic and they have really good vision and they're not really bothered for, you can watch them because many cases of vitreomacular traction releases by itself without the need for surgery. So if it's a patient that maybe the vision is not too compromised and his symptoms are very subtle, I tell them the options and we can watch it, maybe see the patient in 3 months and see if it's getting worse and take it from there.
How would you follow on? I mean, you follow the patient every like couple of months, 3 months. What's the
Yeah,
follow-up
like
intervals?
I usually give them an Amsler grid and a near chart so they can check their vision at home. I think that's very helpful. And then I would see them about every 3 months or so.
Okay, great. So, the panelists agree that unless the patient is symptomatic, we would treat. Otherwise, if we see such a picture on OCT, we would just follow up like every couple or 3 months. We can go for the next question, please. So start with the treatment. Ytria or ochriplasmine which is a pharmacologic vitreolysis best used for vitreomacular traction less than 1 disc diameter in size with no epiretinal membrane. So yeah, 95% of attendees got this right. Dr. Rao, I know that you have a good experience with using Ytria, which is now, I believe it's discontinued for many reasons we'll get touch on. So what do you think about the indication of use of Ytria? Do you use it for like any vitreomacular traction, or you have some criteria for use of Ytria?
So I don't have a vast experience. I have just a limited experience. I'm sure Dr. Maria might have more experience than me, but I will share my experience with Ytria. So the thing is, there are a few classic indications. I'm sure you're going to touch upon these in your subsequent questions. But if you're looking at vitreomacular traction, it's very, very important for us to look at the size of the attachment, because if the size of the attachment is more than 1500 microns, then generally it has been shown in the various registration trials as well that Ytria is not a good, the success rate of Ytria causing a cleavage and inducing a PVD is less likely. So you have to measure the foveal attachment if possible. And again, look at all the scans, because you might find some areas where the attachment is smaller, some areas the attachment is wider. But you always want to look at the attachment and then decide based on the size whether the patient is fit to undergo Ytria injection.
And if you have an epiretinal membrane associated with an attachment less than 1 disc diameter, would you inject? No,
I will not inject, because sometimes you often see a leaf of the epiretinal membrane, which can then sometimes progress over the posterior hyaloid, you know. So in those patients also, the outcome is very poor. So eyes with epiretinal membrane, even if it's a focal small attachment, I'm not so keen on giving Ytria to these patients.
Dr. Maria, in your experience, what's the most common problem or complication apart from the cost Ytria use?
Well, the fact that it costs more than a vitrectomy and doesn't really work most of the time. Well, I don't use Ytria anymore. Ytria in 4% of patients can cause severe visual loss in the trials, unexplained. So the original indication was just for areas of a very localized area of traction, but many of those are the same eyes that would release by themselves, you know, if you watch them. So, so those are cases I would watch. The other option is to inject gas. We know that an injection of an expanding gas bubble, perfluoropropane or sulfur hexafluorine, can also cause a complete PVD in these cases. But that said, I do not use Ytria anymore, and I can't think of anybody who's still using it. So.
There are also a lot of problems with Ytria. I think the cold chain needs to be very, very strictly maintained. and we would have issues with this, So this was in 2014 or 15 when I used for some of the cases. I remember just one case. There was a patient who had a small macular hole with a vitreous still attached to it. And at that point of time, everyone was talking about Jetria, and he was not keen to undergo surgery. So this is the only patient where I had a very good experience. I injected and the macular hole closed. So it was a very small hole. You can say, hardly any. You could just, it was just seen on one scan. So I don't know whether it was Jetria which really worked or something else. So,
What is that?
Absolutely.
What is the time frame you expect that it releases traction after injection of Jetria? It's like after one week, 1 month, or is it?
So literature says that if it does not resolve within 28 days, then it's very, very unlikely to resolve. And the majority of the separation occurs in these first 1 to 2 weeks.
Okay, great. Dr. Hussein, do you have an experience with the Jetria?
Hello. So regarding the Jetria, I don't have any experience, and in my community, I think nobody wouldn't afford it, and even it's available, it's very difficult to do. But I will rather go for any surgery rather using this Jetria, even if it's available. I practically no experience with the Jetria, please.
Anyway, it's mostly discontinued since 2021, I guess. Let's post the next question, please. All of the following factors would favor use of Jetria in association with idiopathic macular hole cases. So you have macular hole case with VMT, as Dr. Rao said earlier regarding his case. The age of less than 65 years, medium, hole size more than 400 microns without Okay, so yes, hole size more than 400 would be not a good candidate for Jetria. So Dr. Rao, your patient you injected with the small macular hole, what was the size of the macular hole? Would you use it for larger than 400?
I think maybe 150 microns or something. It was a very small hole, very, very tiny hole, very small hole. So that's why, as Dr. Maria said, it was probably just luck.
So what do you think the mechanism, if you release the traction, how would the macular hole, closes without surgery?
So I'm sure we all know the history of macular hole surgery. Kelly Wendell, when they first published, they used to just do a vitrectomy, isn't it? Just do an induction of PVD and majority of those holes closed. So I think that's where the basis is. There's some persistent traction, anterior posterior traction, which causes the pull on the macular area and causes a hole. So if you induce small holes, generally we don't even want to do a ILM peel. You can just do you do a vitrectomy and put a gas bubble. Some people even don't put gas, they put air bubble. And these holes might spontaneously close, with time.
But again, it's even a small hole, its effect is not like 100%, at maximum 30 or 40%. Do you agree, Maria?
Jetria success.
Yes.
Yeah. Sorry.
Because I'm aware of some retina specialists used to inject it for small macular holes, and they just 70% of cases go for surgery even after injection of Jetria.
Yeah.
Would you agree in this?
So I had a patient who had multiple drusen, and I'll probably show you his OCTs pre and post. So he was so keen on waiting for Jetria that he waited for 6 months for Jetria. Eventually, Jetria was not available, and he underwent vitrectomy. So I have his pre and post images. I'll show it to you.
Okay, well, you can share your screen if you have it right now, Dr. Rao.
I'll share it? Okay.
It's interesting after all that hype before regarding Jetria and the use of Jetria and how amazing the results, that it ends up with unfortunately discontinuation.
It was called marketing. Marketing.
So this would have been sort of an ideal candidate, isn't it? He had just two focal areas of traction, a large cyst, subretinal fluid, and multiple drusen. And he kept on waiting for a period of 6 months. Eventually, nothing happened, and finally he underwent vitrectomy. And after vitrectomy, you can see this normalization of the foveal contour, and everything looks normal. In fact, even if you look at the drusen, they seem to be slightly lesser in size, especially if you look at the lower ones here. They seem to be lesser after the vitrectomy. I don't know how it works, but you can
It's
see.
interesting because some of the theories of age-related macular degeneration could be traction or so.
That's it. Yeah. Traction makes it worse. Yes.
Yeah, traction makes AMD worse, right?
But if there was actually, I was looking at this afternoon because I had a lot of patients who had exudative CNVM with associated vitreomacular traction. In fact, there are a lot of papers that say that vitreomacular traction is a consequence rather than causative factor in exudative CNVM. So if you have exudative CNVM, probably there's some abnormal attachment of the vitreous which happens, and the vitreomacular traction is supposed to be occurring consequent to the exudative AMD rather than as a cause.
It's though it's I think it's not common, Dr. Maria, to have traction with AMD. It makes it worse, but this case is interesting.
Because they're older patients. Many of them have already had a PVD.
Yeah.
Great. So
let's stop sharing. Yeah.
Let's move. Nice case, Dr. Rao. Thank you for sharing. Let's move to the next question, please. We'll move to another mode of management, which is pneumatic vitreolysis. And management in managing symptomatic focal VMT has a higher safety profile and lower cost than ocriplasmin. Okay, it's interesting that 25% think that ocriplasmin is better than pneumatic vitreolysis in terms of the safety profile and the cost as well. Any of the panelists would consider pneumatic vitreolysis for VMT before surgery?
I have not considered it, because even though it can work in some cases, the incidence of rhegmatogenous retinal detachment and causing peripheral breaks is high. So if it's someone that I would much rather do surgery in those cases. I can check the periphery, make sure there's no break. I think it tends to be safer. But if it's someone who cannot undergo surgery for another reason, I think it is something we can consider, but we need to check the patients very well and have them be cognizant if they start seeing flashes or floaters, because it is not uncommon to have breaks in the periphery from the gaspa.
What do you think the incidence of like tears with or without detachment with the pneumatic vitreolysis, Dr. Maria?
I think it is between 5 and 10%.
Okay, this is quite high. Yes,
Dr.
Dr.
So the issue here is any injection when we do, we tell our patients to watch out for floaters and flashes. Now, when you're doing a pneumatic vitreolysis, you actually want the PVD to occur, isn't it? So the patients are going to have if it's a successful procedure and they develop floaters, then they come rushing to you saying, "Doctor, I have developed these floaters." So it's sometimes difficult for us to if unlike in other, like for example, if you have done an intravitreal anti-VEGF injection and they develop some abnormal floaters, then you're looking at inflammation and blah 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 other things. But here you actually want them to develop floaters, so it's a little difficult to explain to the patient and for them to differentiate whether they have some PVD associated complications or not.
If you think if you think that with symptomatic PVD, the incidence of breaks can be up to 15%, we should expect about the same when we are doing the vitreolysis. Yeah.
Dr. Hussein, do you have an experience with pneumatic vitreolysis and VMT?
Yeah, I had the experience, but it's not good one. So I never prefer it to do the pneumatic vitreolysis. I mean, if there is a need of any, I mean, even you can search the periphery and whatever you want to see the retina, because before pneumatic vitreolysis, I mean, you never know the where the vitreous is attached at the anterior retina and how it will pull. Even any during the examinations, any symptomatic brace you wouldn't find, but it may end up in very bad situation. And believe me, when the patient gets the detachment in pneumatic vitreolysis, he doesn't have a one break, he has many breaks, and it involves all the areas. It's not about the one area or abnormal adhesion. So I would rather prefer to go for surgery if VMT is causing any visually significant symptoms. I'm saying visually significant symptoms, then we can go for VMT. I know nowadays everyone with the small gauge vitrectomy, and they are very much trained doing the vitrectomy in 20 minutes or 30 minutes. I don't know what they do in 20 minutes doing the vitrectomies, and they leave the vitreous more than as it naturally exists in the vitreous cavity after the surgery. So I think doing the vitrectomy is in a VMT if it is a visually significant in the patient has the wisdom. All else people are doing, and people are suffering the consequences of a simple VMT. Non-visual significant ends up in delayed complication like retinal detachment and many more. So think wisely and perform with the wisdom.
Okay, great. So none of our panelists are really enthusiastic to do pneumatic vitreolysis. Again, I'm aware of many surgeons are using this before surgery, but I would say if we can consider this for patients who cannot do surgery or for any reason.
But the issue is the patient who cannot do surgery and he has a visually significant symptoms. Then what you would think if he gets a more complication of
Would go
a
surgery.
pneumatic, and if he gets a rheumatogenic detachment, then what that patient would like. So
Would be
it is not about liking or unliking. It is about what will give the benefit to the vision of the patient and what it wouldn't. So liking and unliking is not that important in terms of treating the visually significant VMT, I think. And the retinal surgeon should have a courage, and he should have a such counseling that he may convince that patient who wants his preferred surgery. His preferred surgery intervention wouldn't give the results. It's rather should be the decision of retinal surgeon.
Great point. Thank you, Dr. Hussein. It's a great
Welcome.
point. Let's go and post next question, please. So if you would use, if you would use a gas for pneumatic vitreolysis, is sulfur hexafluoride has a higher percentage of VMT release compared to C3F8? So again, studies have showed that C3F8 has a higher percentage of VMT, not the sulfur hexafluoride. So most of the attendees got this, right? And we discussed the pneumatic vitreolysis in details. So we can go to surgery now. We can post next question. Can we post the next question, please?
I have a comment on the SF6 and C3F8. We should remember that SF6 pure expands 2 times. So if we inject 0.3, we're going to get 0.6. C3F8 expands 3.3 times. So we're going to get a much bigger bubble, which would cause much more traction on the retina with the longer act, with the C3F8.
Okay, so with the higher percentage of release with C3F8, you get higher percentage of complications as well.
Exactly. Exactly. And it lasts almost 2 months. Yes.
Great. Okay, we can post next question, please.
I think maybe this is the last question, Dr. Muhammad.
There was some questions. Okay, we can discuss surgery now, which is the definitive, we can say it's a definitive treatment of VMT. And I think Dr. Rao has some videos to show us about the techniques of surgery in such cases.
Dr. Maria, would you like to share something? You have some videos?
No, I did not bring videos because I'm in the airport at the moment.
Okay.
So I can't.
Okay, so I'll actually show you some interesting cases. So this is a patient. Sorry about that, 1 second. So this is a patient who presented with vitreomacular traction, and can see a defect right going up to the RPE, right? So this is a patient who naturally you'd opt for surgery, isn't it? And when she underwent surgery, this is the outcome. So this is a follow-up of almost 3 years. And she has excellent vision after that. So you can see near normalization of the contour. I've done some myelin peeling, so she has this dimpling on the side, but the eye looks very good. Now, having shown you this photograph, I just want you to remember this photograph, and I'll show you some more images of this gentleman. So he's a 76-year-old physician. He's a very senior dermatologist. And he also has a similar kind of a picture like the previous lady in 2017. But he opted not to undergo surgery. And lo and behold, you can see the outcome happening. Okay. So this is a few months later. You can see how the foveal contour is changing. And this is sometime later. Now note that the fovea there's still traction at the fovea, but you can see that I really cannot explain how this has happened, in the sense how his, how his traction has actually gone almost resolved. There's no separation of the vitreous, there's no PVD, but the outer retina has become really normal, and I continue to follow him up. So this is, if I go back, I'm sorry, I'm not able to go back. Okay, so this is after a few months more. He still has this little traction there. This is December 2017. This is March 2018. This is June 2018. And this is October 2018. So in fact, unlike the first patient, this patient has got better and better. And this is resolution of the morphological changes in the retina without a PVD. So I really cannot explain how this has happened. So this is
what happens is that, if the vitreous starts detaching more in the posterior pole, which tends to happen, as it continues, maybe detaching more towards the periphery, the amount of traction exerted on the fovea can be lessened.
Yeah.
So I think that is what we actually see here. What is interesting is that many patients actually, it resolves by itself by detaching completely, but this is a beautiful case of how the cysts resolved, because here you almost have a full thickness internal hole, right?
Yes.
Except for the very, inner retina there. So this is a very, very interesting case, how all that, just with, changes in the specific traction on the fovea per se from the vitreous, which is a dynamic structure that changes all the time. Yeah.
Son, was your patient symptomatic earlier with the early?
Actually, he was not symptomatic. His vision was like 0.9, almost 1, even with this defect.
But there was a defect in the outer.
Yes. But still, he had a 0.9 or 1 vision.
So it's all OCT findings, I mean.
Yeah, it's a OCT finding which got better. And I just want to point out something here. You know, when I was going through, I just saw this image now. And when I was reading, there's a term described for this. It's known as the cotton ball sign by a Japanese group. And what they say is you see this hyperreflective lesion right under the fovea between the EZ and the photoreceptor layer, outer layer. And this is indicator of anterior traction on the fovea. So
Okay.
maybe this could, progress as the PVD becomes more and more. So this is,
when you have the dynamics of traction, when you have like anteroposterior traction, this would affect the outer layers of the retina.
yes.
While if you have a tangential traction, you would have like affection of the inner layers of
Inner
the
layers. Yeah.
So it has been proven even by simulation. I think there's two famous papers that did some computer simulations, and they were explaining the dynamics of traction. So, and this is also, your case is a good example of a patient who is showing great changes by OCT, but is still asymptomatic. You didn't go for surgery. You just opted for...
I actually recommended him for surgery.
Huh?
He refused.
You refused.
with this kind of OCT, I'm sure all of you would recommend him OCT surgery, isn't it? But
right. He's 0.9.
yeah, 0.9. But you'll always worry, right? If this flap gets lifted off, you'll have a full thickness macular hole sitting there.
Is interesting.
But I think I'm lucky. I'm really lucky that I didn't do anything.
I think if you would showed him an Amsler grid, he might be aware of some of the changes. I mean,
yeah.
Let's go for surgery. See.
So nothing great. This is just a phaco-vitrectomy in a patient with a vitreomacular traction. I'm just going to skip the phaco part because this is routine. And this is where the interesting bit comes. So I put a lot of triamcinolone. I'm a fan of triamcinolone when I do my vitrectomy. So when you put the vitrectomy port inside, you do some core vitrectomy. And then as you start, the important thing here is when you're doing the PVD. So the PVD has to be in such a way that you're not causing persistent or extensive traction on the macula, because that can lead to a sort of a macular hole kind of a thing. So fortunately for me, in this patient has a focal traction. And as I was doing this peripheral vitrectomy, the traction just got released. You can see it's completely released and pretty much everything was fine. And this is post-op for the patient, pre and post-op. Good, the system, the fovea is resolved, vision improved. This is the patient which I was mentioning to you about, the one who was waiting for the oculoplasmy. And for him, the surgery is not, it was pretty straightforward. I had actually done some minor. So ad peeled is ILM actually, and post ILM peel. It's a very old video, but post ILM peel, this is how it looked pre and post. So yeah.
Do you peel ILM in all cases of VMT?
I tend to peel actually. I tend to peel, especially if the patient has a large cyst in the center with a very broad attachment. I'm a little skeptical in peeling.
Dr.
But
Maria, you do the same. You insist on peeling the ILM in every case, especially if you have an ERM in association.
No. I don't peel the ILM routinely. If it looks very wrinkled, I may, but I always look at the OCT because if it has large cysts, I'm very worried about peeling even epiretinal membrane right on the fovea. So I treat it like a foveosthesis case. So if I'm going to peel epiretinal membrane or ILM, I leave the center because, you can definitely unroof it and convert it into a full thickness macular hole, which we don't want to do.
Yeah, this is actually, I was going to ask how would you, what's your technique in order to avoid the de-roofing of this very thin layer of the cyst underneath with no support below? There is a special
what
technique?
I do very similar to what you have shown here so nicely, which is I start detaching the hyalin in the nasal side, and then I very, very slowly, when it's detached, I just trim it with the cutter so as not to exert any traction. So that if it comes off by itself. So I'm just circumscribing around it.
So Dr. Rao, you are showing us great videos. This is another case.
Okay.
Yeah.
So this case, you use the forceps rather than the.
Yeah. So I feel
what's your cutter setting in cases where you are, there is very thin roof?
Pardon, I didn't hear that.
What's your occutome settings?
Cutter settings are it's actually like I almost go to my shave mode when I'm doing a perifoveal sort of cutting the
very low vacuum.
300. So we start with, when my foot switch goes down, it will almost be 100, and gradually I go up. But it's like 10,000 cuts with a shave mode. So the cuts are very gradual, very slow all around. And I generally do with a very high magnification. I use high magnification lens on these eyes.
Okay, great. What's your setting, Dr. Maria, for those cases?
I always use the maximum cutting rate. So if I can have 20,000 cuts per minute, I would use that. I like to use 25 gauge, usually for these cases. And I control the vacuum with the foot pedal, but I usually keep a low vacuum, like you said. And I like using a Macular contact lens, even though I routinely use the biome for the case, so that I can really see the fovea better. And I can be more gentle, just, with the cutter, trimming the vitreous around the fovea itself.
And then
because I have had cases where I have inadvertently caused a macular hole. So I'm very careful, yes.
I think the intraoperative OCT plays a very important role in these patients. I think this is one indication to use an intraoperative OCT. At the end of it,
yes, that would be great, yes.
Yeah, just to assess and see, because if you land up with a hole, then you might as well put a gas bubble and ask them
to discuss if you have like iatrogenic or inadvertent macular hole. What would you do, Dr. Rao?
So if it's a small hole, generally it might be a small hole.
It heals by itself.
Pardon? No, I'll put a gas bubble and ask the patient to maintain a prone position.
Okay. But sometimes you discover this post-operatively and you get like a very small, tiny hole. Like, right, Dr. Maria?
Yes.
So it usually closes on its own, right?
It usually does, yeah.
Okay.
So you can always, if you discover it afterwards and you don't have gas in the eye, there's two things you can do. If it's very small, you can give the patients Predforte and a non-steroidal drop, because we know that very tiny holes can close just with drops. The other thing that you can do is you can do an exchange in the office and put a gas bubble in, without having to take them back to surgery. If you just left fluid in and you find the unpleasant surprise afterwards.
Okay. Because so you wouldn't go and for another surgery and peel the ILM, just wait till you see some signs of healing of this very tiny hole with the eye drops.
Or I would, or put a gas bubble in, do an exchange.
Great.
So this is a patient who's diabetic and has a vitreomacular traction and epiretinal membrane. So this is pre and post surgery. And I'll show you a photograph of a patient who's again diabetic. So he had this fibrovascular proliferation and a vitreomacular traction and an active subretinal neovascularization called preretinal hemorrhagia. And this is post-surgery. So pre and
this is great, Prasan, because if you have, I was going to ask, if you have a VMT in case with diabetic macular edema, and it's like a focal, small attachment, would you inject anti-VEGF or not? This is if you have like diabetic macular edema with signs of VMT, and sometimes we encounter this, would you go for injecting anti-VEGF?
This patient like this patient actually had multiple injections and didn't resolve. So finally we had to do a treatment for him.
Yes, if I have had that experience that if I have edema with traction, whether it's, or even with adhesion, the edema doesn't tend to resolve with anti-VEGF in diabetics. You know, we usually have to resort to surgery, no matter how many injections we put in, because of the tractional component.
We had, if you remember, in previous episode by Dr. Amri, Dr. Magdi, who was an expert in medical retina, showed an opposite case. With injection, this traction was relieved and the edema is getting less. So
That can happen too, yeah.
Means regarding injection in such cases. Okay, great. You have other cases?
No, that's it.
Okay, great. I think we have covered most of the VMT management, and Dr. Hussein already left us. He had
yeah, too late for him. Yes, it's almost 2 o'clock midnight.
Yeah, well, almost. I think we covered. Would like to have question from the attendees if they have any.
There is so many experts with us in the attendees, Dr. Joe Ruka and others. If anyone want to add or have to add any comments, he can raise a hand. We can just let him be in the panel so he can give insight about what we have talked. What do you think, Muhammad?
Sure, of course.
If there is anyone to comment, please just raise the hand so we can open the mic for you. And Dr. Bassam Nawaisha also there, also very eminent. We are proud that we are having also in the attendees very eminent also and expert people. Or they are satisfied from what already said. So if there is no questions, so we can just conclude. Anything before we can conclude?
I think he has a flight.
Dr. Maria.
Dr. Maria, thank you for
Thank
being
you,
with
Dr.
us
Maria.
at the airport.
Oh, thank you for having me.
Have a flight
It
to
is
catch.
I love the discussion and great cases.
Thank
Dr. Rao, that was wonderful. Thank you for having me.
Thank you for coming, joining us.
Bye-bye.
Thank you so much.
Thank
Bye.
you very much. Sorry
Bye-bye.
we keep you guys from
Thanks.
the airport, but it's very nice to have you. We learn a lot of experience.
Yes, I'm here.
Also, we are having Dr. Hussein. He was too late, so today is very difficult. But anyway, thank you very much for all. Thank you, Dr. Muhammad, for this excellent moderating and questions. Dr. Brassam, Dr. Maria, Dr. Hussein. Thanks for all our attendees for being with us. And we hope to see you, inshallah, next week. Thank you very much.
Thank you.
And
Thank you.
Bye-bye.
Bye.
Bye. Thank you.
Thanks a lot. Bye-bye. Bye.